The ovarian wedge resection is an option to help drastically improve hormones and cycles within 3 months. Now, I had a patient who came back to me after a few years. I'd given her a whole bunch of resources to read about PCOS, to guide her self-healing. She came back for a surgical consult for an ovarian wedge resection. We reran her lab, and I was like, "You don't need it anymore. You healed yourself, just like you." And she was a very severe case.
Today we have the amazing Dr. Naomi Whittaker with us, who's a board-certified OBGYN and a fertility surgeon who's truly shaking things up in women's fertility. She's all about treating the root causes of gynecologic issues and infertility with her unique approach using something called the Creighton model and NaProTechnology, which stands for Natural Procreative Technology. We dive into the importance of understanding your cycle, the benefits of cycle charting, and how it can transform your reproductive health. From eye-opening insights on bioidentical progesterone to the limitations of traditional reproductive technologies and why personalized care is so crucial. You'll want to tune in because Dr. Whittaker's approach not only helps women avoid or achieve pregnancy naturally, but also tackles underlying health issues like endometriosis and PCOS. This episode is packed with valuable information, so trust me, you don't want to miss this. And don't forget, if you find this podcast helpful or interesting, please like, comment, and share. It really helps spread the word, and I am so grateful. Thank you. It's time for confession. Dr. Whittaker, the way that you approach how you treat women's reproductive health seems to be different to the traditional way that most people are familiar with. I'd love to know, what are the key differences between your approach and what led you to the unique approach that you seem to use in your practice?
Yeah, so the foundation of what I do is based on the individual woman's cycle. So each woman that I'm able to do this type of treatment for is aware and educated on her biomarkers. So she knows exactly when she's ovulating, which is a key event of the menstrual cycle, which is easy to miss. It's not easy. You can't just have someone walk in the door and have a treatment option for them. They really have to be invested in their own body and knowledge and be able to invest time and education and in charting and really understanding that, and then coming to you with that cycle data. And so because I have that, I have a unique window into her health and what's going on in her body. And with that information, I'm able to use specific days on what's going on to do testing and then cooperative hormone treatment, which is very unique, as you know, I'm sure. It's not done really for women who are cycling. They're basically left to fend for themselves or be totally suppressed.
Most women don't even know when they're ovulating. Like, that's a really key part that I know most women are not even sure how to track or ovulate. But you do something called NaProTechnology, and I'm wondering, how does that differ from other types of reproductive technologies like IVF? Like, what is the difference and what is NaProTechnology?
Yeah, so nanotechnology technically is under a wider umbrella of restorative reproductive medicine. And so it's just a way of treating root cause issues. I mean, and so it's using very evidence-based knowledge, which unfortunately there's not a lot of evidence. So we have limited data for this, specifically PMS, especially. But we use science and whatever scientific principles, physiology, as well as often smaller research studies to be able to work with a woman's body to correct any underlying issue.
So is the nanotechnology related to that reproductive restorative medicine side of things that I've heard you mention before? Is that it's specific to women's fertility?
So women's health, right? Which women's health is fertility. And so that's what we're most well known for, because that's where I think most women have the hardest time finding care, because it's either eventually IVF or bust. And many women don't want that for one reason or another, or they fail that. So that's what we're known for. But what is infertility? Infertility encompasses usually multiple health issues, not just one, but multiple health issues on both the men and the women's side that cross over time. And I kind of explain this to patients that it's a statistical issue. The more obstacles that you have with health and physical or hormonal barriers, the more likely you're going to have infertility, subfertility, or prolonged infertility. Really, it depends on how many things. That's why it's hard to totally predict success rates per person. But usually I can get to a good place where we've crossed off all the boxes. We've corrected so many things. Their cycle charts look really good that I'm like, I just had one message me today. And the last visit I said with her, I said, I really think We've gotten everything. I don't know what the holdup is, and yeah, after 8 years of infertility, she conceived. So, sometimes we get to a place and it still doesn't happen right away, but, once you correct the hormones, correct the mechanical obstacles, you can really find answers. And, hormone imbalance, these women have often PMS symptoms, for example. That can be a sign of a hormone issue and a health issue. And that is more likely to coincide with other health conditions that women have. It seems that certain women tend to have it all: endometriosis, PMS, abnormal bleeding. And then the more of those issues you have, the more likely you are to have actual fertility issues as well.
Oh my gosh, as I said, I have so many questions for you, and I'm like, how do I break this down and go back to simplified? So the question I want to go back to, if I go all the way back to the beginning, I guess, is why is the cycle charting so important? Is it just for women who want to get pregnant, or are there other benefits for women in general to be cycle charting?
I think every woman should know the basics of her cycle in high school. I think we should know that we're not fertile every day, and that when those fertile windows begin and end, and how to identify that. And then on top of that, a bonus, which is what the Creighton model system is designed to do of cycle charting, is be able to write it down in a scientific way so that it's interpreted and able to be studied by researchers and physicians. So that same cycle data can be used to treat underlying health issues. So it can be used in multiple ways: to avoid pregnancy, to achieve pregnancy, and to monitor health.
What is the Creighton model? I've heard you mention this a couple of times in some of the content or the podcasts I've listened to you on. What exactly is it?
Yeah, so there's different types of natural family planning or fertility awareness-based methods, and this is one of them. It's a cervical mucus-based method. It's similar to the Billings method, but more standardized in the observations and how someone tracks it. And so a woman or a couple go to a formal instruction session, an introductory session, which goes into the whole basics of the physiology of the menstrual cycle. We love when both partners are able to go, because then he can really understand what's going on. When my husband went with me, he caught on a lot quicker than I did. Actually, I tended to overcomplicated it. So you're taught about the physiology. I was in medical school. I learned so much from this intro session that I wasn't taught in medical school, which is so sad. I tell my patients all the time, if you go to this intro session, which sometimes are free, depends on the person giving it, you're going to know more than most doctors about the menstrual cycle, which is mind blowing. But anyway, so just knowing what's going on, why, what you're observing, estrogen rising, increases cervical mucus. That's when the fertile window begins. Whenever you see mucus is fertile. The intro session is a group session. It's, PowerPoint presentation to learn about hormones and how normal hormones function. And then that woman or couple will break off individually with an instructor to understand her specific biomarkers. Because as you know, every woman is unique, every cycle is unique. And to be able to have an accurate way to have family planning in a natural way, you really need to understand and not miss any observation and be very observant and, rigorous in learning this accurately if you want it to be accurate both for achieving pregnancy or, health monitoring.
Are you then in that case, correct me if I'm wrong, I thought I saw something where you said in terms of the Creighton model, you said you were doing 5 draws at one point. So are you suggesting like you're doing like biomarkers, like you're actually doing 5 different biomarkers in a certain phase of the cycle?
So the Creighton model system is the foundation of NaProTechnology. So the Creighton model system is just the observations and teaching instruction and being able to plot the biomarkers. So applying that scientifically to hormone draws in the medical side, that's when you have the NaProTechnology side. Yeah, there's so many layers to it. And I was very confused at first. So yes, what can we do with the cycle charting data? Well, most people say, oh, get cycle 21 labs. Well, that's not good. Cycle day 21, you have no idea. She could be pre-ovulatory still, especially if she has PCOS, for example, or a stressful cycle. So cycle day 21, if progesterone's low, it doesn't mean she doesn't ovulate. It means she hadn't ovulated yet in that cycle. Now, if a woman is charting her cycles, and we love for women to have at least 3 cycles of charting before we run labs so that we know, okay, well, that month she ended up ovulating really late. We would like her to be pretty aware of what her normal is, and then we can run tons of tests on that. I mean, cycle day 3 labs are a nice baseline because the hormones haven't changed yet. They're not really rising, so it's her baseline. So an ultrasound or lab at that time, we're going to see kind of when everything's quiet. So if there's a cyst there, that's really abnormal, for example. Or if, certain hormones are really off, we can really know, okay, that's accurate. It just isn't dependent on her cycle. It's her, where when her ovaries are resting, where her hormones are. So for example, FSH, which is kind of what I described as a report card of the brain ovarian communication. And so based on the cycle data, because we know when a woman ovulates, we can do both a peri-ovulatory estrogen profile. And so we can watch that hormone estrogen rise. And that correlates with the type of mucus that we see. So once the estrogen gets past a certain point, we'll see the mucus change and it'll turn into a more fertile type. And that on a microscopic level means it's changing as well for fertility, which is really fascinating. And then once a woman identifies her peak day or the last day of mucus, the most accurate predictor of ovulation more than ovulation prediction kit, then we call that peak day and we base labs off of that. Then we want to watch that hormone in the luteal phase. And so for PMS specifically, we wouldn't do peri-S for that, peri-ovulatory profile. We would just do a luteal phase profile. So the second half of the cycle, we would tell them to get draws equals 3, 5, 7, 9, and 11. And we watch both estrogen and progesterone at that point, and we want to see them rise and fall a certain way. And sometimes we see, well, most common one we see is just an overall progesterone deficiency, and probably type 2 luteal phase defect. And so we just the whole time the progesterone's low, super common. Sometimes we see a late rise of hormones or an early fall of hormones. And I would say, I would love to do, I'm starting to try to do research on this, but I would love to know which hormone is the most potent, for PMS specifically, but we don't really know. There's not really data on that. I'm sure you know, but that would be the place to start, is to prove we all intuitively know hormone drops are what cause PMS. And we do see that correlated on the hormone chart. We see it correlated with abnormal bleeding and luteal phase defects, which, let's say we didn't run labs, we would see that either with a truncated luteal phase, premenstrual spotting, which is 3 days or more, PMS symptoms, but also variable luteal phase is also something very abnormal. So we like to see a consistent luteal phase from cycle to cycle. That's a sign of health.
What's the deal with AMH, so that anti-Müllerian hormone? A lot of women are suggested to have it, as a predictor of fertility. I've heard you mention this before, that it might not actually be the best predictor of fertility, that it's better for PCOS. So I would love to hear your thoughts on that specific test.
Yeah, I almost never draw it because I think it causes stress, with very little benefit. It doesn't really change my management. The reason why fertility doctors, which by fertility doctors, I mean doctors who specialize in IVF, that's what we, right, REI physicians, I think we really should be calling them, IVF specialists, just so that women know, okay, that's who you're going to, that's their specialty. But they use that as their main screening tool. Are you going to be successful with overstimulation of the ovary to get a high quantity of egg? Because the higher quantity of eggs you get, the higher the success rate will be, or theoretically. So someone who's a poor responder, poor AMH, that's the only thing that it's really good for, is a predictor of responsiveness to ovarian hyperstimulation. So whenever they study it for other things, for example, predicting menopause, it's not accurate. Yeah, so really the only other thing it's good for is PCOS, which typically, if it's severe enough to cause the AMH to be that high, other labs are off way before AMH. So again, it doesn't really affect my management. It is definitely a way to cause stress. And these women already have enough going on. I don't think it's helpful.
It's not a real clear indicator, because obviously there's many friends I've had before, including myself, where that level of AMH might be dropping, and then the fertility doctor or the, gynecologist, OBGYN is saying, look, you're going to need to go do IVF, your egg count's dropping, you're looking like you're going to become infertile. So it's really not that accurate of an indicator. And as you said, it's going to add more stress and do more
Not
harm.
for natural. The thing is, you have to really be, what's frustrating by physicians who say that is you have to be very specific. Are you talking about natural fertility or IVF? It doesn't make sense if your AMH is low to do IVF, because that's predicting low success. And then AMH, we have lots of case reports on women conceiving with low AMH. So naturally, because you only need one egg. And so what I see is in women who are going through premature menopause, their ovaries will still sputter. They will still randomly release an egg. Otherwise, impossible pregnancy to happen. Obviously, statistically, like I was, referencing to before, I don't give them all the hope in the world, and it can definitely be harder. The women that you can see that don't really respond to medication, they often will just, not often, but the ones that do conceive will eventually ovulate on their own. We don't understand why that happened, but it can happen. If they're cycling, technically is possible. Especially if we covered all our other bases, we cleared out endometriosis, we make sure the tubes are open and optimized male side, and we set up everything we can for success. For some reason, they can release an egg and conceive. Even I'm sure I don't check AMH, so I don't have a great. Except I do check FSH. So I've had one with her FSH was over 30 and she conceived. She was not ovulating. We threw everything at her. And she just conceived by her own.
Naturally.
Naturally. Yeah, she had horrible endometriosis. She was told to get a hysterectomy. We found cancer. I wrote it up. I'm hoping to get it published, but
endometriosis, then I'm going to go off on that tangent. So it's often misdiagnosed. It can take years to diagnose. Why would this be the case, and what advantages are being made to potentially improve, early symptom detection? Like, I know laparoscopy is the kind of gold standard, but I'd love to hear your thoughts on endometriosis.
Oh my gosh, it's a big topic, right? I
know.
Has to be kind. Like you said, surgically, unfortunately, it's the only way to confirm and diagnose. So that's definitely a huge obstacle. I think the symptoms are very deceiving, right? They can mask or appear to be other issues like IBS, it could be just GI issues. Sometimes that could be infertility or endometriosis. Other times it could be just infertility and no other symptoms. So when I asked them, I started giving my questionnaire that I designed, which I think is probably one of the more accurate ways to screen for endo is symptom questionnaire, but really understanding the atypical symptoms, as in things other than pain or what type of pain. Or a lot of women will say, well, my pain, I feel pain, but it's not as bad as my friend who collapses on the ground and vomits every cycle. I say, and I'll talk to them, but what about your pain? I know you're belittling your pain, even though you're not collapsing. Tell me about your pain. And then when they describe it, it's still very abnormal. And then they may also have infertility. And so it just presents so differently. I think that's also a problem. Our medical system tends to, I don't remember where I saw it, but I've seen like algorithms recommended for women with bowel symptoms to get a colonoscopy first before a laparoscopy, so some of the medical guidelines are, I don't think, always the best. It depends on the whole clinical scenario. If they have GI symptoms, what other symptoms are they having? Are they having painful intercourse, for example, or infertility, or lots of abnormal bleeding? And then the disease itself is very complicated to treat surgically. So if you're a family doctor, you don't have the tools to do surgery, so you're not going to recommend it. And then if you're an OBGYN and you're afraid of endometriosis because it's so complicated, you're going to be more hesitant and try to do alternative ways to manage it. So I think it has to do with all of that.
I saw you once mention, and again, correct me if I'm wrong, where you said there were potentially lesions that you were seeing that were in, or bits of tissue that were in other areas of the body, not necessarily local to that specific area, or did I completely misread that?
For endometriosis?
Yes.
Where else I found it?
Yes.
Yeah, so appendix, diaphragm, and I had one that was coughing up blood during her period, and she had it on her lungs.
That was the case that I'd heard. That for me was very eye-opening.
Yeah. She's doing much better. No.
I'm
But
glad.
I know, she's suffering when she said she kept going to the ER, and I took care of her for a while, and we first did the pelvic surgery before she was coughing up blood, and she was doing a lot better there, but then she was going to the ER, and they saw something on imaging, because she also had something around her heart too, a nodule, and they're like, you're fine. They send her home, but she's coughing up blood, and she knows that's not right. and she's wanting more aggressive surgery. I'm like, wow, if you must really be suffering if we talk about the risk and you still want to do it. And so, I found a great cardiothoracic surgeon to work with. So we did it together, and she's feeling a lot better.
Incredible.
It was a horrible recovery though, so it was really hard to see what she went through.
I have a question for you on PCOS. So, for women, I guess, with PCOS as well, what are potentially some lifestyle changes that you would recommend to manage the symptoms? Like, I'm someone who previously had PCOS. I had I was 16 and they had said you have PCOS. I've now basically most of those symptoms have reduced due to, my own lifestyle factors, certain things to manage, certain, supplements. I've even heard you talk about inositol before, but I'd love to know what your thoughts are on what are the lifestyle changes that someone could do to manage these? Like, can you detail these specific categories like exercise, diet, supplements? Like, what are the different categories that you would include for maybe more of a holistic approach to PCOS instead of just straightforward metformin?
Right. Oh yeah. No, I would never go straight to metformin. I mean, ideally, understanding your body through cycle charting, understanding what your symptoms are, ideally getting labs and knowing, do I have insulin resistance? How bad is it? Do I have vitamin D deficiency? Understanding the risks of PCOS. Unfortunately, it's a health syndrome that we don't totally understand, and there are lots of flavors of PCOS. And so lumping every single woman with PCOS into that basket of she must be insulin resistant, she must be lazy, or whatever the bias is totally incorrect, right? Not all women with PCOS are overweight. In fact, a lot of the more severe PCOS patients are thinner. And so really it's this predisposition that it's its own unique thing that if you kind of hack it, you kind of understand it, you can hack it and really optimize your health. Yes, you're kind of programmed in a way that's unfair, that makes it harder to just have regular cycles, which most people take for granted, but it is possible. Like you said, I mean, so really it depends on what's going on. But high protein, especially eating breakfast, good sleep, definitely exercise. So weight bearing exercise tends to be really beneficial. But really, I explain, something that you really enjoy, really. I mean, something that you're going to do. So even if it's high intensity walking 5 times a week, just being active. And women with PCOS, fatigue is an issue. So boosting those endorphins through walking, even, or whatever is doable, is most important. It's just doing something, right? And being committed to it. Now, starting that when you feel like terrible is going to be hard. But as women see progress and they have support and they're told, okay, it's not your fault. And also they're educated on all the health risks long term if they don't do anything, or if they don't understand their issue, it could lead to cardiovascular issues, cholesterol issues, sleep apnea, and just, poorer quality of life that could only get worse later, type 2 diabetes. And so all of that is prevented, is able to be prevented with lifestyle changes. So optimizing vitamin D, since most of women with PCOS have low vitamin D, preventing endometrial cancer by cycling either through lifestyle changes or potentially some progesterone support, hopefully getting support in optimizing weight if that's an issue, either through addressing thyroid issues, which are common, or insulin resistance. Yeah, and just getting that targeted PCOS support.
I 100% know it's possible. Like I said, I was told when I was 16 I had it. I had a period maybe every 3 months, 4 months, 6 months. It was very random for 15 years. And by the time I hit 30, I was put on metformin as well. And I lost a significant amount of weight on it, had all these other side effects, basically decided to come off of everything and really went hard at understanding what was happening in my body. I have a period regularly every month now, like clockwork, 28, maybe sometimes 30 days. And that's been happening for a good, 8 years now. I ended up, same thing. So I know it's possible. I have ultrasounds now every 2 years to see if there's any cysts, no cysts on the ovaries. My hair doesn't fall out
Wow.
anymore. Like, I know it is possible to reduce
It
those
is.
symptoms by, as you said, addressing what else is happening in the body, lifestyle, supplements, inflammation, all these different aspects that we might not be necessarily looking at.
Sometimes metformin or some other prescription to help with cravings, with insulin resistance, for a period of time, it may be what is needed just to help, whatever we can get that first boost of confidence, of energy, or weight loss, or whatever is needed to kind of turn that corner and have hope. And then hopefully the goal is though, I mean, it's great you're able to get off. Things like myoinositol, which is very similar to metformin, is more natural, potentially long term only has health benefits, I would think, not potentially nutrient deficiencies like metformin, but some women need that and it's great for them. And then other women, there is a surgical option that's not offered very much because not many surgeons know how to do it anymore. But the ovarian liposuction is an option to help drastically improve hormones and cycles within 3 months. Now, I had a patient who came back to me after a few years. I'd given her a whole bunch of resources to read about PCOS, to diet her self healing. She came back for a surgical consult for an ovarian liposuction. We reran her lab, and I was like, "You don't need it anymore. You healed yourself, just like you." And she was a very severe case.
I want to move though to progesterone. I've heard you talk about it multiple times, and you even mentioned something about progesterone withdrawal can result in seizures during the luteal phase, and that using then bioidentical progesterone can help. Can you break it down for the listeners and explain what exactly is premenstrual seizures?
Yeah, I mean, it's really rare events, and it's specific seizures that only happen like PMS onset, where, it's like they about 6 days before the onset of the period that certain women have onset of seizures. Yeah, I do have a colleague that I believe did treat. I think she used injections of progesterone. I think those are what cross the blood-brain barrier, the VEGF. In the study, they used capsules, which apparently can work as well. Then orally would be second best to reach the brain. But yeah, so what does that show? There's not a lot of studies showing luteal phase hormone issues correlating with medical issues. So that's why I really liked to highlight that because I'm like, oh my gosh, there's literature actually admitting that a hormone drop in the luteal phase causes hormone issues at a very specific cycle time. But obviously, it's not going to work for every woman because it has to specifically be targeted at the right time for the right person. And so I think that's another reason why hormones and hormone support in cycling women just aren't studied. It's just complicated to do and to prove.
What are your thoughts on bioidentical versus synthesized progesterone, especially even during pregnancy? Like, I have seen that progesterone can be really, really helpful in potentially even the first trimester. But what are your thoughts on using bioidentical versus synthesized?
Well, synthetic is not safe in pregnancy. So it needs to be some kind of bioidentical form of it. And so, yeah, to me, that's a big red flag. When I was really trying to figure out bioidentical versus synthetic, I call them progestin, not progesterone, because to keep it clear, because that's another issue in the literature when you do look at research. They will call progesterone, synthetic progestins, progesterone, but then you read what they use in the study, they're using synthetic progestin. And so it's really important that we hopefully get that awareness out there that they're very different and they need to have a different name because they're very different chemicals. I think what really opened my eyes to, I would start with Provera in my residency training very early when I didn't quite understand the difference. They don't really teach you in medical school or in your residency, your specialized OBGYN training. They don't really teach you the bioidentical versus synthetic. Basically, they treat it all the same. And back then, back in the day, bioidentical was still pretty new and harder to access. It was much more expensive. So when we were working with our clinic population, which tends to be public aid, the option of bioidentical was much harder to sell to this population. So I was prescribing Provera, which is synthetic projected cyclically only to try to help women, for example, with PCOS cycle again. And then I didn't even realize that it was harmful in pregnancy, and I was giving it to women who were cycling and potentially fertile, right? Because I'm inducing a period in them. And so when I found out these are dangerous in pregnancy, that I'm like, wow, that to me is pretty telling. If it's not safe in pregnancy, then it obviously has some other effects, unintended consequences that natural hormones don't have. And so we see that. We do see, I mean, the synthetic progestins kind of hijack some of the great components of progesterone, especially if they bind the lining of the uterus extra potently for endometrial precancers, for example. Now, because they do bind the receptors differently, they affect different tissues very differently. So, in unhealthy ways, for example, like breast tissue. So when you use bioidentical, you're going to have potentially only health benefits. There's really little to no evidence that progesterone, even in high doses, is harmful for anyone. I mean, even women who are pregnant with male babies, it's not going to harm them. They've tried to say certain things, but nothing has been able to be replicated as far as harm for unborn male fetuses. And so, and potentially there's a lot of medical uses. Not only do you talk about seizures, but also just any traumatic brain injury. There's some research in the ICU setting, women and men with traumatic brain injury. So imagine that applied all around when you keep looking and looking and reading about progesterone, which, yes, I'm obsessed with because it's just amazing, is healing hormone. It's healing for the brain. So what is that for the unborn? It's neuroprotective. And so that's by its design is to protect the developing baby's brain. So I think that's just amazing in of itself. So yeah, it can be used for adults neuroprotection, but also the unborn. So if there's too much, potentially it can protect your baby's brain and, cognitive development. So there's really little downside to supporting pregnancies with progesterone. Now, progesterone can cause constipation and, sleepiness, so it has certain side effects when it's super high. And so there's alternative routes, such as suppository, that tend to have a little less side effects. And so not only does progesterone, obviously, the pregnancy hormone, so it's supporting, the blood flow to the placenta, development of the placenta, and probably many other things, but we know it's very important to sustain a pregnancy, prevent miscarriage, especially in the first trimester. When they studied progesterone support in the first trimester for recurrent loss, they actually showed a reduced risk of preeclampsia in those women as well. So there's very potent anti-inflammatory effects, and it probably really helped with that placental connection, which is likely linked to, later onset preeclampsia.
Is it something you'd suggest then? Like you said, there's the first trimester that they could be taking progesterone. Is it something that they would take through the whole pregnancy, or it's more crucial in that first trimester?
Yeah, so for our high risk population, we do offer progesterone monitoring in pregnancy. So women who have had losses, have infertility, have PMS, certain risk factors, we offer that support. I don't think I would deny anyone to take it if they really were worried, though it's probably not needed financially, or stress wise if they don't have any risk factors. But I'd say the most critical is in the first trimester. It's less likely to be needed because, the placenta takes over in the second and third trimester. So typically that's fine. But what I've seen, I've researched myself of my own body. I always have low progesterone in pregnancy. But when I supported my luteal phase, I have very severe luteal phase defect. My estrogen should be 120. It peaks at 40 some cycles. When I support my luteal phase with HCG, I did that before my this cycle. Then I conceived with my fifth baby. My progesterone levels were high the entire pregnancy. So clearly, there's more to the luteal phase implantation and the progesterone or in the placenta taking over than we even understand. But supporting both estrogen and progesterone in that luteal phase led to an extreme change in my hormones the entire pregnancy. I thought that was really fascinating. It's a case study of myself, but it's fun to experiment on yourself and really gain a deeper understanding.
What about using progesterone in postpartum? Like, is it something that could be used? They give birth, as you said, even we're seeing like postpartum depression, PMDD, those sorts of things. Is progesterone something that could be taken postpartum to sort of boost up and counter some of these effects?
Yeah, we have a protocol for that. And women with PMS infertility are more predisposed to postpartum depression. There's probably some relation to the receptors and how sensitive they are to the hormone changes, and there is an abrupt drop after delivery. And yeah, we see some very significant postpartum depression in these women. And so we give a shot of progesterone sometimes before they leave the hospital if they have a history of it. And or at the first sign of postpartum depression, we'll give them a shot, and within 24 hours, they should feel better. And so if they don't, obviously there's another issue. Or if they do, okay, we monitor them closely and they call us if it starts to wane. Sometimes that's all they need, and other times we need to continue them on a few shots, and then we transition them to capsule. We used to do this without much scientific backing. It's all based on very small research, but very clear results. I worked at a hospital where one group, a NaPro physician, was doing it, and had some colleagues notice the results, and they were not of the same mindset, but they started using it because it was just so obvious, the improvement. And it's so cheap. I mean, the downside is it is painful, to get a shot of progesterone in your butt. Very painful. But clearly, if you're suffering enough with postpartum depression, it can be a huge game changer. Now, there are two forms of FDA approved versions of this now. So we can say it's the same mechanism of action. It's a little bit, in the pathway of hormones. It's a byproduct. It's a little more potent directly on the receptors on the brain, the GABA receptors. It's a little more potent and targeted. So if you give the bioidentical progesterone, it needs to be converted, and it is. But this FDA version is already broken down as a very, very potent byproduct. And it can be given in two ways, either an IV infusion over 3 days. The woman has to be stuck in the hospital, which is not ideal for someone who has such a postpartum depression. I mean, if you have to, and that's the only option, absolutely it's needed. And I recommend if that's the only avenue you have to get help. But being able to get a shot and go home and go back to your home environment away from all the bells of the hospital and the nurses waking you up is going to help with healing. And the other version is an oral version. That one definitely can't be taken while breastfeeding. Breastfeeding would have to be, pumping down during that time. I don't remember the IV version, but that's another huge problem in that population. You can't breastfeed, and that was part of what you wanted to do. That's going to also not help the postpartum depression or compliance. If you need it and you have to pick between your own care or nursing your baby, a lot of women are in that situation, are going to choose their baby. And that may be because of their depression. They're feeling like a terrible person, and it may not be rational. But I see those are some major obstacles to getting those treatments, potentially, plus the cost. The IV infusion is 30,000, 30 American dollars. And for now, the drug company will offset the cost, but I don't know long term how long that will be available.
What is delayed cord clamping? I've seen a story that you did where you mentioned, I think it was a couple of cases of delayed cord clamping. Why is it beneficial for baby and mummy?
Well, it helps.
And what is it?
So it's just allowing the cord to pulsate for a minute after the birth of the baby, as long as everything's going well. Mom isn't hemorrhaging and baby's doing well. It helps give extra blood flow to the baby, which will help baby from having iron deficiency later on. And iron is very important for brain development. I'm sure there are other nutrients and stem cells I know they're in the cord. I assume that's also going through it. I'd have to look up all the details of all the nutrients and things. And I'm sure there's so many more that we don't even know. There's a reason why the cord continues to pulsate, often much longer than a minute. And especially in the vaginal birth, if there's no bleeding, letting it go much longer is definitely an option as well.
Is it something that women would have to request? Like they'd have to say, look, I'd like to do delayed cord clamping, or is it something that some physicians would be aware of and also suggest? Like, what's the process, and what is it more of the patient would need to advocate for that themselves?
Usually, yes, because we tend to be pretty impatient as physicians. Midwives are more likely to do it naturally, but and again, there's always that caveat. Well, if you're hemorrhaging or baby needs resuscitation, there are kind of medical reasons to cut and pass the baby off for help or help the mom. But if everything's great, it's a wonderful option and has potential health benefits.
There's been some talk that you've also mentioned about PRP, so platelet-rich plasma. I've done this in like my knee to repair cartilage, but you've mentioned it for ovarian rejuvenation. Why would someone need ovarian rejuvenation? What treatments are commonly used today, and why would PRP be something that could be a better alternative?
So like you said, PRP is pretty new, and it's fitting down a patient's own blood for growth factors to help with healing, blood vessel support in places. It's typically been used in orthopedic surgeries where blood flow is an issue and healing is an issue. So someone decided to apply that and said, hey, well, it's being injected everywhere nowadays. Like right? Like facials and stuff. So I haven't looked at all the other things, but apparently it's just this amazing thing. But someone had the idea to try it in the ovaries, and it's mainly done at IVF clinic. It's based on very limited data for now. There's definitely more coming out about it, but the risk is low other than injection, potential bleeding from actual injection. But what you do is you inject the concentrated part of the blood with the healing factors in it into the ovaries. And this is done typically for women who have, for me, I mention it to women who kind of at the end of the road of their ovaries functioning. The case reports that were really compelling to me were women that were in that perimenopause window, and they were able to conceive naturally from it. And so what I do see is FSH improve cycles. So I've only done a handful so far, but I have seen someone who I thought for sure her ovaries were going to be done. And we've gotten a good year or more now after the PRP. And her FSH kind of went all over. It went up and then it went down, but it was for sure going up and we were going to be done for sure. Like totally shut the door. And she was successful and conceived once after infertility, and I'm hoping for one more. And we know, she and I kind of know, okay, she's kind of like, okay, this is not a great prognosis, but let's just try. Let's just do things that are healthy and not risky for you, and see if we can just keep the window open a little longer for hope reasons. And so she's gotten that from the PRP. And so it's really good for women. It's a really good option when you feel like you run out of options, and potentially help restore ovulation issues, help with cervical mucus issues, potentially, theoretically, help with a thin lining. I've seen that improved in research as well. It's nice when, what I liked about it is it really helps with natural conception too. It's mainly used for IVF clinics because IVF success has not greatly improved since its beginning. And so they're going to be really excited to add anything to their therapy to make sure numbers look better, because, the numbers are going to get them more business. Plus, they can charge a pretty penny for this TRP. They charge, depending on the location, if they're in New York City, I think they charge $3,000. If they're in a smaller city, I think they charge $2,000, and they usually do it transvaginally, kind of like they do egg retrieval through ultrasound. So I do it at the time of surgery, and I know some endosurgeons, I believe the Endometriosis Center of Atlanta uses PRP for women who want fertility, but also for lesion formation. There's really no data on that. They say they have really good success with that, but it may have other benefits as well.
It's so interesting. I'm PRP, like, it's when I saw it on your, I think it was your Instagram, I was like, "Wow, they're actually using PRP for ovaries," whereas I've used it,
Yeah.
as I said, for my knee, but it was just something I had never heard of before, and it was just such a fascinating approach. So yeah, very interesting. What about birth control pill? There are many women, PCOS, endo, even PMDD, they're placed on the birth control pill. And I'm seeing that they're having a lot of fertility issues after being on the birth control pill. Even my own clients, some of them end up experiencing really severe psychological issues while on the birth
Mhm.
control pill. So I'd love to know your thoughts on birth control pill, fertility, all those sorts of things.
Well, if, like we talked about before, women who have more issues, like PMS, PCOS, are going to have more severe symptoms. So when they go to the doctor, they're going to be more likely to be put on the pill. Does the pill directly harm fertility? I haven't seen clear data for that. There's some theoretical reasons. I mean, well, nutrient deficiency, for example, or potentially hormone receptor changes, as far as when the hormone receptors have been sensitized to a very potent version of hormone, perhaps they may not be as sensitive in some cases to the more biological active. That one's more theoretical. I would say more likely is masking symptoms, and then age is the issue, because when you're on it, you think you're okay. You forget how severe it was. You forget how bad your pain was. You forget how irregular your cycles were. So you're on it for 5, 10 years, and then you get married, and then you don't get off until you're ready to conceive. And by then, you wanted a baby. Probably like you want it right then. Like you've thought about it for a long time, and so typically by that point, you start trying, And then 6 months to a year go by before a doctor will really even see you. And at that point, you wanted a baby a long time ago. But you're way behind the 8 ball because you forgot, "Oh my gosh, oh yeah, I had PCOS or I had all this pain. I don't even know what that means." So then you're starting fresh at the workup. But to me, that's the main issue. Not realizing that that's a health issue that needs correction and investigation, lack of awareness of the cycles, right? You're not gonna have any reason to chart your cycles then, or awareness of when you're ovulating. And then you're most likely much older now and behind the 8 ball in investigation. So it's mainly that age component and delay of diagnosis and workup. And then unfortunately, our system says they don't need a workup until at least a year, unless you're 35. But if you're less than 35, you need at least a year of, of trying to conceive randomly, not even cycle charting. With cycle charting, you can half the time to conception and evaluation. So if a woman walks in the door and she's young and has been trying for 6 months and she knows her fertile window, that's very abnormal.
Who should not use IVF in that case as well then? Like, I have heard you talk about in some cases, like cases of PCOS might not be the best choice for using something like IVF. Is that correct?
Yes, so women with PCOS are probably one of the highest risks for IVF and its complications short term and in pregnancy as well. So ovarian hyperstimulation syndrome is one of the big risks of IVF. And it happens, IVF after I trained under said pretty much all women with PCOS get ovarian hyperstimulation to some degree. Now you can have mild or you can have moderate or severe. Severe is very scary, very rare. You can be hospitalized and have end organ damage, kidneys can shut down, for example. Mild is more common, bloating, the ovaries are enlarged. So part of ovarian hyperstimulation syndrome is you grow the ovary, and so the fluid is released in the abdomen and in the body to try to compensate for that. The body needs a good fluid balance, and if it's off, it can affect other organs. So the ovaries are already quite enlarged in many women with PCOS, not all, as we talked about different flavors, but there's certain PCOS women that have huge ovary. And so if you stimulate those more and they have all these follicles already, those follicles are going to erupt. And then those ovaries are going to get huge. And just that alone is uncomfortable. Add that a whole bunch of fluid. And the whole goal is to super ovulate. And those women do. They greatly respond. Plus, why? Women don't. I almost never need injections for women with PCOS. That's not how you treat it. Really, you need to just figure out how to get them to release one egg. Most of the time, it's just trying to get their hormones functioning back to normal. So progesterone support, lifestyle, or even just simple ovulation induction medications or the wedge resection. And that way, it does take longer, but if you treat it correctly, the testosterone levels are going to lower, their insulin resistance is going to improve. With that comes a healthier pregnancy. Well, first, a singleton pregnancy is the goal. You really only want one baby because twins increase the risk of all the complications of pregnancy. So does IVF, even more so. So preeclampsia, gestational diabetes, preterm birth, even death to the baby are increased with IVF. And then add that PCOS and the health issues if they're totally ignored. So just like we talked about, the pill is a reason to ignore health issues. So is IVF. Oh, well, we can just go around it and we can get the baby. Well, it's not that easy with PCOS either. If you try to go around the issue and force superovulation, we have high testosterone, severe insulin resistance, high cholesterol, and you're throwing tons of hormones at the body, that's when you set up a high-risk pregnancy. And, I've definitely seen that. If we get women on myoinositol and we continue it in pregnancy, that actually lowers the risk of preeclampsia and gestational diabetes and helps lower the size of the baby for a singleton. The risk of having a really big baby is decreased. So being able to optimize vitamin D, reduce testosterone, potentially will also help the health. Let's say if you're having a little girl, if she's exposed to high testosterone, there's a theoretical higher risk she will have PCOS. So that's found in mouse studies. So if I've had women say that I'm so worried my daughter's doomed for PCOS. Well, and especially with women who are infertile, I'm like, well, you're investing in your future daughter by getting the surgery and reducing your testosterone or cycling on progesterone or optimizing your insulin now. Hopefully that means your daughter won't have it. If she does someplace mild, then you'll know how to manage it. But you're doing everything you can in this time to invest in your health and invest in the health of your baby.
Yeah, my mom had PCOS. That's why I was
Oh.
nodding because she had it. Same thing. Where I had a large, she had the hair loss. I had all the symptoms of her. Like I used to
Oh.
have to pluck my chin because I had the hair growth. But she had PCOS. Had a hard time getting pregnant as well. Had to go on certain medications. Didn't have to go down the IVF route. Was able to get pregnant. But as soon as I saw that she had it, and then when I realized, this was linked, she had high testosterone, and what do you know, I ended up with it as well. Thank goodness I have been able to really get those under control, the symptoms of PCOS, and that's why I haven't had a baby yet. So I'm haven't embarked on that path yet. So it'll be interesting with all the things that I've done to reduce the symptoms to see how I go with. And I'm past 35 now. So I'm in that, I know, high risk category apparently. So it'll be very interesting when my time comes, which will be hopefully soon. I have a question for you on hysterectomies though. What are your personal thoughts on them? Why should they be performed? What age should they be performed at if you do one? Like we're seeing
Mm.
a rise of women having hysterectomies, and we have obviously conflicted, there's cross-relating studies. Some are saying obviously, under the age of a specific, I think it was around 35, having hysterectomy puts you at a much higher risk for cardiovascular, all these other issues. And we're seeing women with endo having hysterectomy. So I'd love to know what your personal thoughts are on hysterectomies. What age should they be done and why should they be performed and when should they not be performed?
Yeah, it's hard to say specific age cutoff, but yeah, absolutely. Oh my gosh, less than 35 is very, very should be extremely rare. Right? I mean, it should be absolutely last resort, especially the younger the patient, premenopausal especially because you can impair ovarian blood flow and increase ovarian aging, at a quicker rate. Theoretically, right? You're affecting blood supply. And so also for women who are of childbearing age, there's that regret factor potentially. Even I've seen women totally sure that they're done, and then they definitely can regret that later. Life circumstances change, divorce, death, etc. So I do think hysterectomy, well, is used too often. And I mean, I think the uterus is a scapegoat for, pelvic floor dysfunction, endometriosis, for example. And so really what I think women should be investigating is, do I have endometriosis first? And do I have, can I find a skilled endometriosis surgeon who get the disease out? Because yeah, we blame the uterus, but the uterus is responding to the inflammatory environment that it's in. The uterus is very rarely to blame. So for most women that come to me, even young women, they're like, I just want my uterus out. It's a problem. I'm like, okay, just be careful. It's not necessarily the uterus. I always recommend, almost always, I should never say always, I almost always recommend a more conservative surgery of endometriosis excision first. Now, if a woman comes to me a few years later and she's like, look, we tried the conservative surgery and it didn't work. This rarely happens. Actually, the last person that did that, I was like, can we try one more thing? And she's like, okay, what? I said, injections of progesterone. She's like, okay, fine. And it changed her life so much. She didn't want a hysterectomy. Now she's back to try again to conceive. She's a very hard case. I know, but like, it's just changed her life. She said she's never had such an enjoyable cycle. Like her whole life has changed. And so because she's still cycling and had the uterus, we can time it correctly. The problem is for what I do, once a woman had her uterus out, timing things is much harder to figure out. And so if we're able to help her in a dimensional approach, physical therapy, endometriosis excision, the supplements, lifestyle, physical therapy, if we're maybe low dose naltrexone, if we're able to kind of address it in a multifaceted way, the likelihood that they're going to feel a lot better and not want a hysterectomy is much higher, after that. So really that's optimal. There are definitely women that kind of like, just get it out. I want it out. Gosh, that's a really hard situation, especially if they're, very busy or have a lot of social factors. But hysterectomies are a lot more profitable and quicker and easier. So it's also incentivized on that. And, I can praise my colleagues sometimes. I work for a big health system. And, they'll do like 4 hysterectomies a day. And sometimes I can only do 1 endometriosis excision that whole day, maybe 2, if I'm lucky, depending on the amount of disease. Because, I get a lot of bad disease because no one else it feels like no one else is treating it. Eventually they find me, and usually they're the worst cases that have been, looking for so long and suffering. Yeah, so I look much less profitable, even though, endometriosis excision is much more challenging, much more time consuming mentally, physically, much more rewarding, I think. But, hysterectomy is just quick money. Yeah, is it beneficial for some women? Yes, failed endometriosis excision, older, very heavy bleeding, especially if they're end up in the ER and it's life threatening. Adenomyosis and evidence of that, or very suspected, and again, failed more conservative approaches. Those are the ones that I feel more there's definitely a level of confidence I like to have before I do some definitive, irreversible organ removal. And so that's kind of how I, approach it with my patients.
Incredibly interesting. Like, as I said, with PMDD, like there's women that are getting hysterectomies. Now, of course, as you said, like over age 35 is better if they don't want children anymore, or they've had their children, etc. But the interesting thing that I found, and this is anecdotal, obviously, this is with my own clients and another PhD geneticist I work with, but what we've noticed is some of the women that are then having the hysterectomy, they already had a sensitivity to some of the hormones changing. They have the hysterectomy, they're put into menopause pretty much, straight away. They're still having potentially symptoms because they're struggling with the menopause. So it's a really interesting topic, hysterectomies, because I definitely
Ah,
noticed it seems to be on the rise. A lot more girls at
so
a young age are coming and saying they're having them.
you're talking about even removing the ovary. That's technically separate.
They're removing the
Ovaries
uterus
are a
and the ovary.
separate procedure. Yeah. So that's, oh yeah, under 30, well, under 45 actually increases morbidity. The earlier death for women who have their ovaries removed, that's much more serious than the uterus, actually.
They're removing them too.
Yeah, I mean, especially under 45. I think I've seen one case in our population where, I mean, everything felt, I mean, I'm saying, 1 in 1,000. I don't know, very, very rare. Let's say we've done everything. But like you say, yeah, surgical menopause is no joke. To go from, I mean, some abnormal hormone levels to none surgically and drastically can also cause, I would think, psychosis issues or other, hormone issues. And then good luck getting hormones replacement therapy after that too, right? Like after that, and if you're a young woman, let's say you get a hysterectomy and oophorectomy, ovaries removed at 38, you really need a much higher dose of hormones to be similar to other women your age to be able to get that bone support, breast support. Most physicians aren't going to give you that aggressive of a medication to be able to not have vaginal atrophy or bone mineral density issues. So, yeah, that's a very sad case.
I've heard cases where there's women that might be having miscarriages, and there's a percentage where I can't remember where I read this study, but it was showing that the men can be just as responsible potentially for the type of sperm quality that is happening in miscarriages. I'm not sure if that's accurate or not, but what percentage are the males being also responsible for women's fertility, and what can they be doing as well to make sure that they have a better chance of having a healthy pregnancy without a miscarriage?
I think it's very hard to prove a man's responsibility. Unfortunately, it's hard. Oh, I saw one viral video that 50% or no, majority of miscarriages are man's fault, and it went viral, and I got really mad at it because you can't prove that. There's some hopefully future research on DNA fragmentation index as far as kind of the oxidative damage that they can see in the sperm. I don't routinely order that test, and I have ordered it for recurrent loss, and it was not beneficial. But I know Dr. Phil Boyle in Ireland, who does restorative medicine there and neofertility. He uses that in protocols. So I'm definitely open to the future of research in that. But I have not seen really clear data to say this woman with multiple miscarriages, it's the husband's fault. I have not seen that. I've definitely seen it more contribute to just infertility, I would say. But the beautiful thing about the reproductive system is that men are designed, women create the one quality egg. They put all their energy into creating the biggest cell of the human body, the egg. But men, they're supposed to make 100 million sperm, and then one little guy is supposed to make it to the finish line. And so by nature's design, it's supposed to filter out the bad sperm. So I think that's extremely protective. Even if a man makes mistakes and drinks and stuff, it's gonna, especially marijuana too, potentially delay conception because the swimmers are gonna be a little mutated. They're just not gonna make it. I think. I could be wrong again. I think DNA fragmentation of sperm is the future. And I would like to see more research, but I don't think there's enough to prove that yet. I absolutely optimize male fertility. I'm sure there's some component. I just don't know. I do think there's some natural selection process for that, and that they have to go through the cervix, the cervical mucus, the uterine environment through the tubes, and then make it because it definitely created a lot of recurrent loss And some of the most effective therapies are progesterone, DHEA, and estradiol. That helps. And I do see a lot of autoimmune issues in these women. Is it somehow related to incompatibility with the man? I'm not sure. Or more of, I think it's more of an autoimmune issue. And so the body's over responsive to an embryo and it sees it as foreign. And so for those women, I refer them to reproductive immunology, and Dr. Kwok Kim is my favorite mentor. So anyone she's trained, she's at the cutting edge of research. And some of these, I've had one, she had over 20 miscarriages and she was able to have a healthy baby. Yeah, amazing.
That is
I know,
resilient.
I know.
Wow.
She's amazing on the Stone A level. I don't know how she got through, but she did all the research. She went and also we did all our therapy. It didn't work, which that's not very common. We gave her everything. We literally threw everything we had at her. So then she ended up going to them and getting on organ transplant rejection and as well as IVIG. And so that's what did it. Yeah, so for men, optimizing their health is really important. And it's pretty similar nutrients that help women help men. There's so much overlap. And I love it when men get on a kind of like a prenatal for men, like FH Pro, Pure Haven Pro, that has a whole bunch of antioxidants, optimizing their vitamin D, their insulin resistance and all that. It may even help with the pregnancy too. There's some theories on that for preeclampsia risk, for example. But I think most importantly is mentally, both partners doing it together and supporting each other because, yeah, when the woman is doing all the work, which obviously, I mean, by nature, women are designed to carry more of the burden. But if a man is not only supporting her emotionally, he can show it by, okay, taking the pill box and some supplements, and we're working out together, and I got a little workup, and, her seeing that, I see a huge benefit to that and her feeling supported and not alone. I definitely see, a subset of couples where it's like, I'm not gonna get tested, I'm not doing anything, I'm fine. That's definitely only hurting the situation and not really a great way to start a pregnancy journey either.
It would add more stress. Like, I totally see that. Like, my husband is we're wanting to look at conceiving sometime this year, and it's been incredible because he's gotten on board with taking all the right supplements, in making sure he's not even in a sauna 3 months before, like,
Oh,
doing
wow.
all the things to optimize to make sure he's also in a good position, and you're correct in saying that it really does make you feel like you're a team and that you're supported, which it just helps with your stress levels. Like, you just feel like when that added stress is not there, that you're doing this on your own and you've got a team member
Yeah.
who's on board, I really think it helps and actually makes a really big difference with potentially conceiving. So, very accurate. If there was one key message that you could share with the listeners with their journey with PCOS, fertility, endometriosis, all the things, what would it be?
You're your own best advocate. So getting all the information you can, asking all the questions, making sure providers supportive of your questions and of your management your way because it's about you.
Thank you so much for being on this episode. It was so refreshing. Like, I have to tell you, it was music to my ears and so refreshing to see an obstetrician, gynecologist that is using such a holistic aspect, but also genuinely seems to care. Like, as you said, trying to find those root causes to the issues with that woman's health. And it was, it was very refreshing for me. I truly wish we had more doctors like you in Australia, especially when it's time for me to get pregnant. So thank you so much for all the work that you're doing, your mission, all the education that you're sharing. I think it's really valuable, and I think a lot of women are going to truly benefit from it. So thank you so much for your time. I know you're a busy lady.
Oh, thank you so much for having me and for your, ability to spread this information. So hopefully one day it will be the future for more women to be able to access this kind of care. If it is good care and it's what women deserve.
Absolutely. Thank you so much.
Yeah, thank you.